The other thing that we've been presenting at this meeting, in the poster sessions downstairs, we've got two posters looking at different aspects of disease monitoring with novel therapies. One that's kind of, with the ibrutinib monotherapy, what we're seeing is that actually patients who remain on treatment, which is the vast majority of treatment-naive patients, they're continuing to respond. So the lymphocytosis resolves maybe 1 year, maybe 2 years of treatment, but then when you look with a more sensitive measure, and it doesn't require anything too specialised, just a simple B-cell count, will show you that the counts are continuing to reduce maybe 1/3 of a log every year. Some patients plateau and stable out, and we've seen a few patients where the counts have started to rise, and 3/4 of those patients have progressed. So you've got quite an early measure with a very simple test for patients on ibrutinib monotherapy of who's likely to progress. And the other patients who've got rising counts still have very low levels, so they're not becoming clinically apparent yet. So I think it's a pretty sensitive way of predicting who's coming to the end of their useful ibrutinib therapy, whereas the results for the other patients who remain on treatment look very good. And then possibly more topical, is the venetoclax ibrutinib trial in relapsed refractory patients, the Clarity study, which was 50 patients in the UK, and we've been seeing improving MRD responses between 12 months and 24 months. But there's still a concerning small proportion of patients who have a higher level of residual disease at 12 months and also at 24 months of venetoclax. And so we've been trying to find a way to predict or identify patients who may be going to have a suboptimal response, because we know from the Murano study that those patients are likely to relapse within a year or two or progress within a year or two. The things that we were looking at were trying to look within the biology of the disease. So we were looking at BAX and BCL2 expression, intracellular expression within the residual neoplastic cells. And it was an interesting pattern. So when you have ibrutinib, the patients get 2 months of ibrutinib monotherapy in the run-in, and you would see about 25% reduction in BCL2 expression and quite a substantial reduction in BAX expression. So BCL2 is the pro-apoptotic and BAX is the anti-apoptotic. And as soon as patients start on venetoclax, the BCL2 levels and the BAX levels both rise. And we're not entirely sure what's happening there, but within the small proportion of patients who retained higher levels of disease, so had more than 1% MRD at 12 months, we were seeing not a very minor, if any, change in the BCL2 levels on venetoclax introduction, and BAX levels were low at the start and remained low. So I think this is an interesting biological thing. You're seeing patients who are maybe destined not to respond to venetoclax. And maybe a slight downside is that it's quite challenging to turn that into a diagnostic thing that people can access routinely. So in the end, it turns out that the MRD level is the most predictive of, the MRD level is an intermediate time point, is the thing that's most predictive of their eventual MRD response. And so the data is just presenting that way. If you have less than 1 in 10 to the 5 in the peripheral blood, then you're very highly likely, 100%, to get less than 1 in 10 to the 4 in the bone marrow at 12 months of venetoclax plus ibrutinib.